Hi, Howard. Thank you so much for meeting with me and being willing to share your story about not just your personal experience with mouth breathing and myofunctional therapy through your son, but also through your profession. You're a doctor, ENT, and a plastic surgeon, right?
Facial plastics and
Facial, okay. So I would love for you to give me some background on your professional side of things, and then I also want to get into your son. So, but let's start with your professional stuff. So, yeah, go for it.
Okay, well, it's interesting because you bring up a good point. The professional and the personal became related in a lot of ways when I started to see parallels, and I know you've had a similar experience, and like both of us, it can make what can be just a research or clinical interest into a passion where you really want to learn more and understand it. So a lot of my real main clinical interest, even during residency and then fellowship in facial plastics, was in understanding the nose, and rhinoplasty became my main interest. And I trained with one of the world-class rhinoplasty surgeon in the early 2000s, a guy named Calvin Johnson. And he really wrote the book on rhinoplasty, and I learned a tremendous amount from him just about kind of the structure and engineering of the nose. And that was in New Orleans right before Hurricane Katrina. So unfortunately, we left right before, ended up in Connecticut, New York area. And there, being fortunate to work for a university and have a private practice, I really got to learn a tremendous amount more just building on my fellowship and my residency from California, where you just kind of get to build a three-dimensional understanding of a problem rather than kind of a cookbook understanding of something. You could just keep expanding knowledge beyond the envelope of what a typical textbook would say or a typical course.
And that's what I appreciated about when I met you. You told me that you talk about mouth breathing with your patients and you talk about function. And I saw on your website that you're doing something called a functional rhinoplasty, which I thought was super interesting.
Yes.
So maybe you can explain the difference between what you do and maybe what a surgeon who's not kind of looking at the mouth breathing as much. I don't know. Maybe I'm even wrong about that. But
no, you're right. The term functional rhinoplasty is actually quite a common term.
Oh, it is? Okay.
Yeah, I by no means did I have coined rhinoplasty terms, but that's not one of them. That's actually a fairly traditional one. It's it's a way of it's like an insurance rhinoplasty in a way where
I see. So it does.
It's a word for doing a rhinoplasty to make the breathing better. So it actually is a fairly wide. Almost anyone who does rhinoplasty will.
Okay, I had never heard it before.
No, that's okay. In general, though, where I do differ is that I think we pay attention to that. So where did it first become interesting to me is we were doing, work. My main interest had been working on rhinoplasty techniques and improving really the structural techniques and trying to make them work better. And then I started to see the connection between rhinoplasty and sleep apnea. Actually, a friend kind of prompted me to look into that. At first I was like, those are two unrelated things. That there's sleep people and there's rhinoplasty people. They're not typically the same thing.
That's so crazy.
And we started, this is maybe 2007 or 8. So we started to look at this stuff, and there's really, at the time, there was almost nothing written, the connection between the two. But the more I started to look at it, and even starting to do some basic testing on myself, realized that nasal obstruction or blocked nose can worsen or at least be contributing to sleep apnea. So
for sure,
by that, I kind of made this conclusion in my head that since that's true, then a proper rhinoplasty should treat or even cure sleep apnea. So we did a study. We got this, what's called ethical board approval from our university, Albert Einstein College of Medicine. And we were able to show that rhinoplasty helped with sleep apnea. But I was really baffled by the failure aspect of it, that it only helped in like 30% of patients. And, you know, as doctors, we kind of tend to go, oh, I guess it's just certain people are candidates and certain are not. You know, that's kind of the typical way you look at it. It burned me up. I wanted to know why. Like, why were we missing the boat on these other 70%? And it wasn't that the surgery wasn't good, because their nasal airway was more open.
Yeah.
So we started to look at subgroups. You know, who were the people who failed? Were they people who had other issues? You know, was there some factor in the surgery? And it looked like it wasn't really the surgery as much as their age. Being advanced age, or their BMI, which is the body, as you know, the body mass index, or indicator of obesity or tone. And those tended to be the people who didn't do as well. Okay, so we were like, all right, young, thin people were doing better, and older people with weight problems were doing worse. And we still couldn't put our finger on why these people were failing, because the surgery was good, like I said, and it was successful. And that's finally at some point either reviewing the literature. I had a conversation with my dental hygienist actually at around this time that I was analyzing this, who's now in dental school, or at least at this time. So while he made this what sounded cockamamie thing to me, I should tape my mouth shut at night.
Oh, really?
About my research, he was talking about that the plaque on my teeth looked like it was from mouth breathing. And I said, well, my nose works fine. How could I be mouth breathing? And he said, well, you can just get mouth breathing without nasal obstruction. And then I said, what? That's key. It wasn't on that conversation. I think I was able to walk home from this appointment, and I realized that those 70% of people, yes, we fixed their nasal obstruction, but they weren't mouth breathing because of nasal obstruction. They mouth breathed because of tone, which is, the jaw structure. So that's where age and obesity, where they have less muscle tone, and age are causing the problem. So finally, after all these years of racking my brain, literally hitting my head against the wall to try to figure out what the problem was, we finally, it's like one of those things, the answer was right in front of you the whole time. You don't have to have a blocked nose to mouth breathe. And if that's the theme of everything I've done since then, that's why I think we hooked up.
Totally, yeah.
Able to meet you, is because finally the answer helped me expand my world of looking away from the nose and more at the jaw structure, the dental structure. So it was a little bit like leaving my comfort zone that made me start exploring oral appliances, and not to treat with those, but to start wondering about it and to see. And it happened to be about this time. So we had our first two kids at this point, and my younger son, Asher, he kind of, as you know, Sarah, has a mouth open kind of posture.
Yeah.
And at the time, his sleep was poor, super loud snoring, super loud grinding. So as these answers were starting to hit my research, I became even more interested and passionate about it as I watched Asher.
As your own kid has it, yeah. You're like, wait a minute.
And I also turned around 40 at this time, and I started to get a lot more complaining from my wife about loud breathing. The dry mouth, dry throat thing was starting to affect me, and I even started to feel that choking feeling that sleep apnea patients had started to describe, and of course it was worst on my back when you lean back. So right around this time, it was like a perfect storm of things that I said, all right, I've spent a long time improving surgical techniques. I feel like those are effective. But now we need to start helping people, that other group of patients, the other 70%. Or even to understand that it's really a human condition, that almost all of us are on this spectrum or will be.
Yeah.
And it's just a matter of understanding, how all these parts play together. In other words, if you have a nasal obstruction, a jaw problem, and you have obesity or age, you're going to have severe problems.
Totally.
If you have only one of the four, you're going to be on the early end, but can develop the other one. So a lot of it is, what's interesting to me is trying to put all these things together and trying to tailor approaches to patients. So in other words, if someone, and we want to explain it all to patients up front. So someone,
and that's the challenge sometimes. They're like, I just want surgery. I don't want you to tell me like other things to do, right?
Right, or the opposite. So you have to, it's not a one size fits all type thing. Even though it is a very common thing, if the nose is severely blocked, mouth closure techniques are not going to work as well until you relieve the obstruction.
Exactly, yeah.
But there's been a lot of interesting things. So we're playing with different treatment paradigms, and for Asher, I know I've given a long answer to this question, but
that's okay.
We first wanted to use mouth closure techniques at night. So we used a technique to support his jaw at night. I didn't feel comfortable taping his mouth. I think my wife Allison wouldn't have loved the seal of it, but I did agree with my, I with the gentleman who suggested it, that the jaw does need to be closed. So we used variation on a diving hood that really is tight under his chin.
Yeah.
He bought in. He's been using it for 2 years. No sign of snoring. Sleeps comfortably. Gets good rest.
And he's a good nasal breather. I mean, you probably know. I think his nose is clear. I mean, he has the ability to breathe through his nose. And what we're trying to do through myofunctional therapy is get that muscle tone, get his tongue up so that the jaw can stay more closed, and then work on the lip seal. And that is the muscle side of things. So I think it comes together perfectly.
Yeah, no, and I really, I had watched some of your videos online right before we met you, and I was like, yeah, that's Asher. I mean, he basically, you can almost see if you saw a picture of him when he first started, he just had like flaccid lip muscle.
Definitely, yeah, it's really common.
He just kind of, has this kind of open mouth posture. And, the typical ENT would look on the inside and say, oh, it's tonsils. Oh, it's something going on the inside. That may be the case, but it's caused, in my view, by a lack of tone and jaw structure.
And then it becomes a habit too. And if you don't change it, it just stays forever. It doesn't just go away in a lot of kids, So then they become the adults that you probably see later with sleep apnea who need rhinoplasties. So that's the crazy thing. Now, I'm curious because are you able to find other practitioners to work with you who are kind of on the same page? I know that's a struggle for me sometimes is when I refer to an ENT, I know that sometimes they don't really get what I do. And do you have a hard time finding people who get what you're doing, or does that matter?
Absolutely. I mean, both in the research publication thing, and even when I give talks or just, whisper to a colleague at a meeting, I get a little bit of a blank look. There is I really appreciate what you're doing with this mouth breathing awareness, even among experts. And I mean, even professors of ENT or otolaryngology at top universities probably are almost completely unaware of the topic. And what's even more amazing is I think many, if not most, conditions that they treat, their initial event that starts the condition is mouth breathing, but physicians have almost a blindness to it. It's literally
so weird.
For example, if you get, then if you want to discuss how it's possible, an ear infection or a throat infection, a lot of times these things, their real origin is mouth breathing, but because it's invisible forces like negative pressure that builds up because of it, we don't see it. So what we see in the office when they come in is the fluid in the ear, or the redness in the throat, or the fluid in the sinuses. And we go, oh, it's inflammation. Yes, there's inflammation there, but the inflammation was due to a vacuum-like effect that happened with every inspiratory breath overnight. And the snoring is actually the oral or sound manifestation of the negative pressure buildup. So we sometimes have the paradigm wrong. So as a physician, you tend to see inflammation or fluids. You go, oh, we have to remove the inflammation and fluid. Let's give anti-inflammatories, antibiotics.
Nasal sprays or
nasal spray. But in reality, if they could treat the negative pressure and mouth breathing before, or either with devices that acutely stop it, or even with myofunctional therapy like I do, which is more of a longer term. You're not going to cure tomorrow's mouth breathing with one day of myofunctional therapy, because like anything, it's like you can't become a marathon runner in one day. You can't go
totally.
I'm training today. But what you can do is what I recommend to both patients and for family members and friends is you need an adequate functioning nasal airway. Then you need to use acutely, or in the short term, things to help you keep your mouth closed. That can be position, it can be an oral appliance, it could be a ACE bandage around your head, it can be things you order online. You can even sleep with your chin under your hand or tape.
Yeah, there's so many things you can try.
They're all basic. The strategy is keep the nose open and the mouth closed, and what tactics you use or what devices you use varies, and I don't know what the best one is. But I do think in the long run, the long-term strategy should include myofunctional therapy, because
I totally agree.
There's no surgery that's going to make these muscles stronger. There's nothing that you can do. Even when I've racked my brain, well, what's a surgical solution for myofunctional therapy? What would I do to make my colleagues happy? Because a lot, you got to also remember it's a business. So no one wants to be like, well, I could do this procedure and make some money, or I could refer to a myofunctional therapist and have it out of my hands. There's really no great options. I
know. Well, so what I tell people, because I don't think myofunctional therapy is the end all be all to everything, but it has to be included in these other treatments. And that's I think what people are missing. Like you're saying, it's not that you don't need surgery. It's not that you don't need these things, but you've got to get the muscles to go along with it if you do it. And that's always something that I've been surprised by, is how many people I meet who've had turbinate reductions and septoplasties, rhinoplasties, and they can't breathe through their nose. And it's not that they have a problem with it, they're not used to it, so it feels hard. And no one ever told them, they've had multiple surgeries, and no one ever said you have to practice actually using your nose. And that, it's just been a surprise to me all this time to find out after talking to you that actually getting people to nasal breathe isn't really part of that process, so.
It's true. And, it should be the model that I see is the way that orthopedic surgeons work with a physical therapist. In an ideal world, and it might be 50 years before this is widespread, that someone who does nasal surgery, there's no way they would undergo it unless the person signed up for myofunctional therapy after. Because when you have been an adult and have been mouth breathing your whole life because of nasal obstruction, you need it's a use it or lose it thing. And I tell the patients that we can make your nose perfect. Let's say I was able to do a perfect nasal surgery in someone. If they continue to let their mouth hang open after the nasal surgery, even if they're using something to keep it closed at night, they're going to end up getting clogged noses because it's like an unused tunnel. You know, if
Yeah.
you if it, and that negative pressure that I was talking about builds up, and that's the mucus and turbinate enlargement that are actually due to nasal underuse. This guy, you pronounce his name better than me, Gemino.
Oh, Christian Guilleminault. Yeah.
I took French in high school, but I still can't say his name. But I have a tremendous amount of respect for this guy.
Yeah.
He's a sleep guy who really is one of the few physician leaders who is aware of mouth breathing and its role in sleep apnea.
Yeah.
And it's the person who I most have understood how the whole paradigm of mouth breathing is backwards. In other words, the tonsils and adenoids don't cause the mouth breathing. The turbinates don't cause the mouth breathing. It's mouth breathing that causes the internal changes, and it's the underuse of the nose that causes those things. So all the surgeries in the world are never going to work if they're treating the visual manifestations of mouth breathing. Only treatments that will treat mouth breathing will work. And the only good long-term one that's best for long-term health and even appearance, as we talked about last night, is myofunctional therapy, or whatever way you can learn to train your muscles.
Yeah, I love hearing you say that, because that's like, it's so hard for me to find doctors that actually say that stuff. So it makes me like so happy, like, oh yay, somebody is understanding like what I talk about all the time. And
way to get it in the business model. And that's
that is a challenge.
A lot of times, I've tried to do device development. If you don't, a naiver version of me would have thought, hey, this will be cool, everyone will like it. But if it doesn't fit the business model,
exactly,
it doesn't get widespread. So we'll have to brainstorm on ways to make the same way that somehow orthopedics and physical therapy were able to integrate their practice.
Well, I know you've
on ways to get that to work.
Yeah, that would be amazing. I don't see the answer either, but I know that you have. I mean, we've talked about some of the exercises that I've said, oh, you could show your patients this, and so I don't know, maybe just giving people like a couple little, like when you see them, just a couple little ideas of like, here's where your tongue should go, or your lips should be together. And I mean, even those little things can probably help the outcomes of the surgeries, right?
Oh, absolutely. I mean, the problem is the other negative of the physician visit is a lot of time there's not a lot of time.
Yeah.
That being said, just like, the rudimentary smoking cessation that you might do, you should stop smoking kind of thing.
Lose weight.
At the end of a rhinoplasty visit, I do talk about mouth breathing. I say, I notice you have this kind of, even though we've done this, your posture is still in this position. And, I'm going to try to give some rudimentary stuff. A lot of them, because, they haven't been introduced to it before, they look like I have a second head when I start talking about their tongue position or lip closure. People are creatures of habit. So when you're used to your doctor giving a prescription at the end of the procedure and not, having you mimic faces with them, they are not expecting that of a facial plastics surgeon or an ENT. So there are people who definitely get it and love it, and and I'll recommend that they call you or another myofunctional therapist if that's what they do. But there's people who buy in, but there's a lot of people who literally are quite skeptical, and it's just hard to bridge that gap. But that's where I think you doing this more, every time you and I talk to someone, we're one step closer. And that's why I said it could be 50 years before this is all widespread, and a lot of the conventional treatments like sinus and adenoid removal for what is actually mouth breathing will diminish, but it's not going to be for a long time.
Well, I think there's a general, I don't know if it's a change or just because now I'm kind of in this bubble where a lot of the people that I work with are interested in root causes and the big picture and like, well, why do I need this procedure done? Like, what led to this? So I don't know if that's just something I'm seeing, but I feel like in general, patients are more interested in like not just solving the immediate problem, but like asking why and trying to get to the root cause. Do you notice that too?
100%. And I think it's a generational thing. People say I'm in this generation X, and the generation before me is the baby boomers.
Yeah.
The younger generation is what they call the millennial and the Generation Z. They tend to question more, and you can see all negatives. But whereas my generation, I think the baby boomer generation and the ones before them, if the doctor said, I'll even ask my parents. Hopefully they're not watching. But if the doctor says you need emergency surgery, they'll
sign me up.
The doctor said it, so we got to do it. The doctor says we have to remove part of your tongue. Well, then that's what gets done. And I feel like the more connected, tech savvy, internet exploring generation and beyond, Instagram using generation.
Totally.
Why are you going to remove my tongue and I have to pay you to do this? So they're a little bit in a refreshing way. They need to know why. And if you're a traditional doctor and you say, well, because I'm a doctor and I said so, they're just going to walk away. And they'll find an online solution like you. So that I do see a big difference. And I still, of course, we see the traditional generation still who say, well, you're the doctor, just tell me what I need to do.
Yeah.
And they're going to mostly be seeing conventional people. And that's why you and I see people who've had 4 or 5 surgeries. They saw any ENTs, they saw headache specialists, they saw dental specialists, they saw an oral surgeon, an orthodontist. And no one ever really addressed their problem, partially because it's not in the educational model and partially because it's not the business model.
I know.
So,
it's really
generation gives me hope. And then I think that as they go on and have kids, they'll be questioning the whole model as well. So I do have optimism that
I think you're right. Yeah, the new generation of people who are asking those questions, and then on top of that, the access to information, which I know a lot of dentists and people in my world don't always like that patients can come in and say, I think I have this, I think I have that. And I actually think it's good that people can learn so much online. I mean, there's a lot of bad information too, but just the fact that you can look on Instagram, like you said, or YouTube or something, and you can learn quite a bit, and knowledge is power. And now you can at least try to solve some problems on your own. And it's a whole new system. I mean, it's kind of crazy. Like, people come to me saying, I think I'm tongue-tied. I know I mouth breathe. I had allergies when I was a kid, and here's what I think happened, and sign me up, And that's so different than the traditional model that I started off in, where a patient would go to an orthodontist or their dentist and notice that, the dentist would tell them, we think you have these tongue thrust symptoms and you should go see Sarah. So that referral model is very different than what's happening with about, I would say, 50% of people find me already wanting therapy. They don't even have to go through the well, do you need it? I don't know. They figured it out and they're like, I want this. So that is a huge change.
It's a much better, I'm sure you noticed the patients are better too, because whereas if you just get a referral from an oral surgeon or orthodontist and you go, I don't know what I'm doing here, but they told me to come and that I had to see, I don't get it. Whereas when you buy in online and they know they want to see you, I have the same thing. Most doctors rely on a referral system from, buddies, people, colleagues type things. And as I learned more about this, I realized, as you said, a lot of my colleagues don't understand this whole concept. So I found that I had to communicate more directly with patients by translating some of my research into online stuff. I'm not as skilled as communicating with
maybe this will help.
But I needed to talk directly to people, and a lot of people are coming directly to me. I have many fewer. I mean, I certainly appreciate my physician colleagues referring.
Yeah, me too.
But the patients that find me because the knowledge of, in other words, you're speaking to them.
Yeah,
and then
exactly.
Something is resounding in their minds about what you're saying. They go, that's me. I get it. So they come in, and those people are much easier, I'm sure you know, to talk to.
And in my practice, it requires a lot of buy-in from people, because it's not just a one-time thing. I mean, as you know, you have to do exercises at home. You've got to get your kids to do it. It's over a long period of time. I mean, I typically do 12-session programs with people, and it's not just like, oh, I'll wave this wand and your habits will change and your mouth will close and everything will be easy. It involves a lot of work on the patient's end, and I realize that. And so I think that buy-in you're talking about is critical to get somebody to go through a program and actually get changes out the other end. For me, I mean, it's like critical.
No, I completely understand. And the biggest obstacle that I think that's going to be in people like you and other myofunctional therapists' way is that many patients want an easy switch. In other words, they want a pill. They want a quick surgery and a quick recovery. So I think, and everything is so easy in our culture. Your car's broken, it's fixed. Yeah. You want to
buy stuff on Amazon. It's super easy.
Amazon Prime. Everything is like immediate. So in your reality, it's like myofunctional therapy. Like you're like, where's the short version? Like where's the weak version? It's there is no real easy answer, but that's a hard thing where it's going to be hard to get the general public. Right now you're dealing with probably more the elite, knowledgeable people.
Totally.
Not high intellect, but they found you, which is
exactly
impressive. It shows that they did some kind of high level of knowledge requiring activity. The vast majority of people who are going to be they're going to be harder to reach, because you're going to be like, well, where can I just take a course of steroids or something, or a laser? Isn't there a laser that can do this?
Exactly. Well, I'm glad that you have been able to share all this stuff from your professional side. Do you want to say anything about how it's gone with Asher trying to change these habits? More from the dad side of things. Like, how has that gone?
Yeah. Well, first of all, it's been a lot of fun. It doesn't sound like it, but I guess I've always been the kind of person that I enjoy like working hard at something and trying to overcome something. That being said, there's days, especially, and Asher, he can be a challenge. I don't love being, come on, Asher, let's go do it.
Or close your mouth.
Yeah, exactly. That being said, I like that doesn't bother me, is taking a long time to work on something. And it's parallel to helping the kids with various sports like lacrosse. It's just, it takes such a long time to learn, but the reward feels so good when you make progress and you see Asher slowly getting to sleep better, and you see that he went from never having his mouth open to sometimes having his mouth closed without someone telling to him. And I think he looks better when he does it. He better impression. And again, the aesthetic, I'm not, even though I do facial plastics, I'm not like, all I think about is aesthetics. But I do think it matters how you present yourself to the world. That if I can give him that little bit of help to train him while he's young, can it help socially? I hope so. I bet. So to me, it's worth the investment and worth the difficulty. And a lot of parents, and I'm sure they'd rather just be like, just take him for surgery and we'll get scream at home and then do it. For me, it's worth every minute, because there's really not a lot of risk. There's no risk. He swallowed the rubber bands, but beyond that,
and those are safe medically.
That's about it. The drama that goes with that is sometimes pretty from it, sure. But in general, he likes it. It engages the kids a little bit. It's a little something to do, and I feel like we're making good progress, and I'm excited to keep making progress. I have a feeling, even though we're doing it for a year, Asher's going to need to always, or at least for some time while he's still in my care is going to need things to remind him and help him and continue to work on that strength.
Well, it's hard. I think adults have much more self-awareness, and we can start to pay attention to our posture or our lips or our breathing, and that is the challenge with kids. And Asher's 9, right?
Mm-hmm. Yes, 9. Yeah.
9. So as he gets a little older, that awareness gets better. And I do see that as kids get to like 12, 13, 14, especially if they start to realize kind of the social aspects around like having their mouth open, they do start to take a little bit more ownership of it. And, you know, what we're doing now is really laying the groundwork with the muscles. And I mean, hopefully it doesn't take until he's 12 or something to actually have a closed mouth all the time. But, you know, you're saying, I think it's going to be a longer term thing. Hopefully not. I mean, I think he has the physical ability. A lot of it is at this point, like remembering and awareness. I mean, and that is so hard with kids, but it's not impossible.
Good.
Yeah.
Well, excited to continue and really enjoy it so far.
Yeah, well, I am super excited that you were willing to share all that information because I think a lot of people will like to hear it. So, yeah, I'm excited to get this video out. Is there any last things that you want to say, or should we just wrap it up, or what do you think?
Well, we've enjoyed working with you. I'm glad to have the opportunity to have met you. We've learned a lot. I've been, I don't know if you mentioned it before, but I've been kind of trying to go through it with Asher, doing exercises. I have my own issues. Obviously, even at night, I'm able to keep my mouth closed mostly during the day, except when I'm talking too much.
Yeah.
But it has helped me as well. And
good. I was going to ask you, what's your feedback from the doctor's side of things doing these exercises?
I wish I could I had enough brain cells to work on it more while I'm working and stuff like that, but sometimes I'm distracted by other stuff. But I think it's a great concept, so I'm excited to keep working.
Awesome, thank you. Well, I can let you get on with your day. I know you have to go back to your clinic, right?
Yep.
Yeah, so all right. Well, thank you again, and I guess we'll just call it a day. That was awesome.
Okay, well, thank you, Sarah.
All right, you're welcome.